that there is a lack of information made available both to physicians regarding this topic, as well as the community. The community some of them may know more than others, but many of them really don't have a clarity. Should I decide on a feeding tube for my loved ones, for myself? Should I put that into my living will? But what if the doctor says this and the rabbi says that? I'm not sure. What am I going to do? I just won't do anything. I heard that more than once. So because the word has to get out there, this is the first. Hopefully there'll be others as well, other opportunities, so we can send out this information. And this lecture will be later on, a day or two. It will be on our website at chicagomitzvahcampaign.com, and you can listen to it or share it with others. When I prepared this talk, I felt that it was really important, really important to talk about how us, Yidden, how do we feel about going to a doctor? Of course, it's important, right? Everybody will shake their head. We have doctors here. We are not like some of those religions out there, lahavdil, that don't believe in it. They don't believe in healing. And, if God causes that you should be sick, if you believe in God and you're sick, then, God will take care of you. Miraculously, somehow, we don't believe in that. It's very important that this should be on the get-go, that Torah believes in healing. So the first two things is, as far as the doctor is concerned, it's important for doctors to know, what do we believe? When they have a patient, one of the first things they ask, tell me your symptoms. Why are you here today? Another good question to ask, who are you? Tell me about your background. Oh, you're Jewish. You believe in the Torah. You believe in God. Okay, then there's something else that I have to know when I talk to this family. So we believe that God is the ultimate source of all healing. Okay, the doctor is only the messenger. It's incumbent upon patients to actively seek healing, but at the same time to remember, Ani Hashem Rofecha, I am God, your healer. As far as the doctors are concerned, it's a mitzvah. We're soon going to see that it's actually, by Torah law, doctors have a responsibility to heal. It's a mitzvah for medical professionals to provide patients with the benefit of their knowledge and experience in accordance with the patient's wishes. One of the things that every doctor will tell you is that we have to, and we try our best to carry out the wishes of the family or the patient, if the patient is, loose, and the religious beliefs. Recently, a patient told me he was admitted in the hospital, and he had to have heparin. Those of you talking, there are some doctors I see online, but I'm talking also to lay people, so I will try to explain everything. Heparin is a drug that's given for people who have clots, they have a stroke, there's suspicion of clots, then doctor will give them heparin, and the hospital a heparin drip. So the doctor goes over to the patient, listen to this, and says to him, Jacob, I want to be respectful. I know you're Jewish. So before I put in the order for heparin, I want you to know that heparin is derived from pig intestines. Is that okay that I go ahead with the order? The answer is yes, it's okay. But the fact that he took a minute of his time to respect the fact that maybe there's a problem. I know he's Jewish, I know he's religious. He's asking for kosher meals. And he went out of his way to ask that question. When doctors know all the facts, they will ask. They do respect their patients and they want to know. And hopefully, after this presentation, they'll have many more questions to answer. And I just, it's very interesting, when I first planned on this talk, I didn't realize that it was Parshat Mishpatim. And actually today is Chumash, Verapa Yirape. It's actually in this week's Parsha, where the Torah says, and the Gemara says, that from here we see that a doctor not only has permission, but is obligated to do so. He is obligated to go ahead, and if there's a patient there that needs his attention, it's not like, okay, I'm the doctor, so I'll do it. By Torah law, he is obligated to do it. And of course, I have the highest respect, and I'm sure all of you too, for any physician. The Talmud says, Hamatzal nefesh achas. Somebody who saves one soul is as if they saved the entire world. You don't realize, maybe we do, when a doctor prescribes antibiotics, he is saving this person's life. If it's an infection without being treated, God forbid it can be fatal. Depends what kind of infection it is. So by him just writing a prescription for antibiotics, he is saving someone's life. And how many times do they write prescriptions? Okay? So there's no question that we have the highest regard, the highest respect for doctors, for what they're doing. Okay. I'm going to spend a few minutes to talk about medical ethics. And the reason why it's important to talk about it, because every single hospital has a department, the ethics committee, that they meet to decide on they resolve difficult ethical dilemmas that happen, especially in the ICU and other departments. That's what they're there for. So once we understand what is the idea, what's behind, what are the policies, what are the principles of general medical ethics, then we'll be able to compare that to Jewish medical ethics and see Torah medical ethics and see where the differences are. And then we're going to get to many, many different examples. We'll talk about DNR and hospice and palliative care, and hopefully we'll be done within an hour. If not, you'll stay longer. Okay. So medical ethics is a disciplined study of morality in medicine and concerns the obligations of physicians and healthcare providers to patients. So it's very important that this department is there. Actually, I was told that every American medical school requires medical ethics courses. So the doctors take these courses, but they don't take courses of Torah medical ethics. They take courses of national medical ethics, whatever, which is important. And that's basically the reason when I find so many times patients tell me, you know what this doctor told me? And he's shocked. Why is he shocked? Because the rabbi told him differently. Well, what do you want? He didn't take the rabbinical classes, and the rabbi didn't take the medical courses, okay? And that's why, as we're soon going to see, it's very important that the rabbi and the doctor talk together. They communicate together so they can share exactly what does Torah say about this, what exactly is the diagnosis of the patient, and we'll talk about that soon. But, and sometimes it's probably more shocking to the doctors when they hear, really? Your mother, your grandmother, you really want to put her in a feeding tube now? She's already 90 years old. They don't get it. Really? Like, what are you doing? I'm going to call the ethics committee on you, because where they're coming from the education, the training they got, this doesn't make sense. It's absurd. And as far as the patient is concerned, he gets all the information from the Torah, from the rabbi, and he doesn't know where he's coming from. So that's why I think it's important that we know more about general modern medical ethics. So there are four major principles of modern medical ethics. One of the first one is autonomy, beneficence, non-maleficence, and justice. What does that mean? This is like Chinese words. So autonomy basically means respect for the patient's right to determine their own choices for their own body, for their own health. And that is number one in that every ethicist will tell you, autonomy. The patient has a right. It's your body, it's yours. We don't believe the same way. We'll soon see the difference. Then, the duty to do good, the duty not to do bad. So basically we are relying on the doctor. This is his medical, as far as medical ethics is concerned, this is his duty to make sure, provide only good therapy, only good treatments, and not to do bad. And then decisions, should we not, especially with critical care patients, should I not, we leave it up to the doctors, the medical team to decide. Is this considered doing good for the patient or not? And finally, to treat all the people equally and equitably. So this is all part of modern medical ethics. The problem with this is, who decides what's good and what's bad? And on what basis? You know, there are different states that have different laws, especially when it comes to brain death. It comes to euthanasia, which is pretty much forbidden everywhere, but there's also what do you call it? There's
medical assistance in dying.
What, pardon?
Medical assistance in dying.
Medical assistance, okay? Medical assistance is something which there are 10 states. There are 10 states right now that allow medical assistance suicide. What that means is basically the doctor can prescribe some kind of a medication, and he tells the patient, you're so ill, you really want to end your life, here it is, you can do it. Okay, the doctor can't do it himself, that would be euthanasia, but he's allowed to prescribe it. 10 states say yes, and the other states say no. So we see, who is the one that decides? When you talk about modern medical ethics, okay, it's up to the governor, it's up to, depending on the legislation, and they have a vote on it to decide, yes or no. By Torah, it doesn't work that way. It's either good api Torah or it's not good api Torah. What about a case where multiple principles conflict with one another? For example, what if a patient wants something that others may consider to be doing bad? Okay? There is, the patient may want one thing, and the ethics committee and the doctors will say differently, or vice versa.
Or the family,
right. When the patient is unable to make the decision, we rely on the family, we rely on the power of attorney, whoever is the one who is the spokesperson for the patient. So again, that's the difficulty with modern medical ethics, because what means to do good, what means not to do bad, who are we relying on, what is it based on? Before I tell you about Torah medical ethics, I think it's very important for us to know major foundations of Jewish medical ethics. In medical care, as in all fields of human activity, Jews are bound by God to follow the laws and ethics of the Torah. We get up in the morning, we say Moda Ani, we say a prayer. And some of us are careful of what we eat. Not because of a diet, because it's pretty kosher. The Torah gives us guidelines every minute of the day. Here you make a bracha, you be careful, don't eat this, don't eat that. Shabbos, Yom Tov, what you do. Constantly we are guided by the Torah. We don't have, our own ideas, and we don't have our own opinion. It's what the Torah says, that's what we do, 24/7. Therefore, when it comes to such a very important subject as what to do with the body when someone is really critically ill, we continue to follow what the Torah tells us. We can't just listen to the Torah, for 90 years, But then, after the 90th birthday, I'll find a different path in life. As such, individuals are not viewed as owners, but rather as duty-bound guardians, custodians of the bodies that God gave them to preserve and protect. So if you saw before, we said that one of the things, autonomy, one of the major principles of medical ethics is autonomy. I have a right. By Torah law, I don't have a right. There is no such thing that I have a right. That whole concept that I have a right and I'm entitled to do this and that, you don't find anything of that. Does not exist, neither in the biblical or Talmudical Torah. It doesn't exist. The whole concept. We are in the hands of Hashem, in the hands of God. We don't have a right. This is not my body. We are guardians or custodians of the bodies that God gave. Consequently, the concept of autonomy should generally be viewed as a responsibility rather than as a right. It's my responsibility. God gave me something, a treasure. That's my body. And I have a responsibility to make sure to take care of it. That's why one is not allowed to hurt himself. Why? Not because it's ethically, wrong to hurt yourself. Not because it's going to hurt. Because God says, no, it's not my body. How can I hurt? How can you damage something that doesn't belong to you? So that whole concept of autonomy pretty much does not, I said pretty much because I'll tell you later of an exception, but pretty much does not exist, 99% of the time does not exist in Torah literature. And here's another thing for us to know, which again, only Torah medical ethics will be able to offer this. We'll be able to say these words, that every moment of life is precious and has inherent value. Many times, especially when the patient goes through palliative care or to hospice, they'll be very careful, but you may hear the language from someone on the staff. The patient is dying anyway. They'll say it in a very nice way. So why do X, Y, Z? I mean, it's a matter of time. He may die in 4 weeks, and you want him to die in 6 weeks. So he's dying anyways. And by Torah law and Torah medical ethics teaches us that every moment of life is precious. Why is the person still around? I don't know. I'm sure many of you have visited nursing homes, and you know there's memory care over there. Many nursing homes now have a memory care unit. You walk around, you see people who are totally not themselves, not conscious. They can't do anything themselves. And if you ask yourself a question, why are they alive? I don't know the answer, you don't know the answer, God knows the answer. I don't know. But the fact that they are breathing, they are alive, that means there's a reason why God wants them here. They have a certain mission here, which is totally, totally above and beyond anyone's understanding. So this is very important for us to know. Then, something you will hear too many times from doctors, quality of life. You ever heard that term from a doctor? Is this quality of life? So, do we have quality of life? Yes, but it's assessed by Torah values. So basically, instead of using the term quality of life, I will change it to value of life. Our life has value. Quality, we are not experts on quality. This is up to God. Totally up to God. And especially if you leave it up to any human beings, whether it's this committee, that committee, or the doctors, to decide what's quality of life, again, let's go back to memory care, into the nursing homes, and you can probably say 50% of the people over here let's do some kind of euthanasia. Why are they living? That's not quality of life. And I'll tell you one more thing. Does a baby have quality of life? Can't do anything himself. He's lying there, has to be picked up, has to be washed. Is that quality of life? It is. For the baby, that's quality of life. We don't know how these demented people, for example, how are they thinking? What's going through their mind? Oh, look at them, it's not quality of life. But from their point of view, where they're coming from, they're having a good time. They're sitting there, they're being fed. Many of them are not complaining. Some of them are, but many of them are not complaining. Why aren't they complaining? Is that quality of life? If I ask, truthfully, it's not quality of life. But as far as the patient is concerned, just like a baby, as far as the patient is concerned, he is fine. He's okay. It's okay, right? But as far as the patient is concerned, it's okay. Now let's talk about the 4 principles that we mentioned before. How is that illuminated by Torah values? So, autonomy. As custodian over the body and life that God gives him, the patient is duty bound to follow Torah law. So it's not my autonomy, what I want to do, as we explained before. In certain exceptional cases, Torah law may leave decisions up to the patient. Now, if you're dealing with a patient, you want to know if this particular patient is the exception of the rule, that's why you need to contact your rabbi. One case, for example, I saw is a patient who is extremely fragile. Extremely fragile, and she, weighs 70, 80 pounds, whatever. Is it okay? And of course, she's elderly. Is it okay to put her on a DNR? Okay, so I saw there is an opinion that says this may be the exception. There are, again, isolated cases, but I spoke to local rabbis who said no, they would do whatever they can to try to convince the family or the patient that they should not put themselves on a DNR, but we'll talk about DNR a little bit later. So there are some isolated cases where autonomy exists, but generally speaking, not. The definition of doing good or not doing bad is not determined by individual preference, professional consensus, or popular opinion. Rather, it's defined by the laws and the ethics of the Torah. All human life is inherently valuable, regardless of a person's age or quality of life factors such as mobility, ability to socialize, enjoy eating food, and more. And I want to elaborate on this. Many times, the question comes up. This patient will no longer be able to walk for whatever reason, okay? And whatever injury or stroke, whatever, they can no longer walk. Again, is this quality of life? Or this patient always enjoyed going places, going to restaurants and going to parties. Now this person is stuck at home, he can no longer socialize. What a life! Is that a reason to make drastic changes? Or this patient enjoyed eating. Do you know what it means? He's not going to eat. He's 7 years old, let's say, Hospice. He's not going to be able to eat anymore, not going to be able to taste anymore, and he food till 120. Come on, how can you let that happen? By Jewish law, by Torah values, this is not a reason to terminate life, God forbid. It's unfortunate that this is happening. Why? Again, we don't know. But if you turn to modern medical ethics, they may sit and evaluate and decide differently. And you know what? And once again, when a situation like this comes up and you present it to a doctor, if it's the first time they hear it, it may be almost like a culture shock. Really? Is this something to debate about? And understand, when that happens, don't think anything personal. When that happens, it's just because he didn't come to this course, okay? Just because he did not go to yeshiva. He doesn't have smicha. That's why this is happening. But it's not because, oh, how can you say that? They're good people. I'm going to say this over and over again. Doctors are very, very special. We should stand up. You know, when a Rav comes in, you stand up. I think when a doctor comes in, you should stand up too. I mean, these are people who save lives. But doesn't mean that they know everything that you and I may know. Okay, now we're going to get to some nitty-gritty. 3 necessities for survival. And again, I can't tell you how many times these questions come up. Oxygen, hydration, and nutrition. So we're going to start with nutrition. And go from right to left. It just happened a few weeks ago. I get a call from someone that this and this person in a nursing home, the doctor said he can no longer have his NG tube. NG tube is a tube that's put into the stomach, NG tube goes into the nose. I'm talking about a G tube. G tube goes into the stomach, a J tube goes into the small intestines. This particular patient had a G tube. And the doctor says that he is aspirating. Many times the reason why patients get a feeding tube is because they can no longer swallow for whatever reason, okay? And because they can no longer swallow, if you feed them, they're gonna aspirate, and that's how they get aspiration pneumonia. So the decision is usually, what do you wanna do? Okay? So again, by Torah law, age is not a factor. Nothing else that we said before are factors. If we can give them a feeding tube, we should. This person, he's still in a nursing home locally here. He's been there for over a year on a feeding tube. Over a year on a feeding tube. And the doctor said the feeding tube is not working. Okay? Anyways, make a long story short, it was not working, but ultimately they changed the formula of the medication that goes in. It's not just one standard medication. I guess some of them have high protein, high calories, so they changed it. And guess what? This was about 3-4 weeks ago, and he's still alive. It's working. So questions have to be asked. Again, the reason why the doctor didn't think of this alternative at the very, very first time, because where is he coming from? The education that he got, the training that he got, doesn't work. We don't have to look for things. He's already a year and it's enough, you know? That's where he's coming from. But we have to know it's okay to ask questions. The doctors are okay with that. Ask them, is there any alternative? Is there anything else we can do if the NG tube doesn't work? Or if the G tube doesn't work, what can we do? So just for your own knowledge, there's 4 different types of feeding besides regular food. The NG tube is a tube that goes into your nose. Usually they can only keep it in there temporarily for about 2 weeks or so. Then a decision has to be made. You know, what's next? A G tube. I remember there was once a patient where the doctor made it very clear that he cannot have a G tube placed because of he had some kind of a mass there. I don't know exactly what it was. He once had a surgery over there, and he cannot insert a G tube. The doctor did not give any other options. I happened to speak to a local doctor, and he says, ask the doctor if a J tube would work for this patient. He didn't want me to ask that question, but I did. And guess what? They put it in, lived for another 6 months. He was a very sick person, but he lived for another 6 months. So a J tube is already a procedure. It's done surgically. It's more invasive than a G tube, but again, it's a possibility. TPN is basically nutrition that goes into IV. They put a special catheter. Again, for some patients, again, it's not permanent. Nursing homes will not accept anyone on a TPN. So it's really temporary. The ultimate decision is G tube or J tube. But what I'm trying to bring out is the importance of having this information so that you can ask the questions when these things come up. Hydration. Okay, should we give IV fluid? The patient is critically ill. And you may have known of different situations where the doctor says, don't give any more fluid. And guess what? They're right. Sometimes giving too much fluid to a patient may be a problem. If the patient has overload, if the kidneys are not working properly, he has got too much fluid in his body, so maybe give him very, very little. But again, this is a conversation that you must have with the rabbis. We'll soon talk how he gets into the picture. The rabbi and the doctor have to come up and decide, should we give some IV fluid or nothing at all? Oxygen. Again, there are different types of oxygen. Sometimes a patient will come into the emergency room and the patient is having such a hard time breathing, they're going to put him on a ventilator immediately. They'll intubate the patient right away. There's no time to make, try this, try that. It's critical, they intubate right away. Sometimes it just goes gradually worse and worse. Okay? So nasal cannulas, you probably had your own experience in the past where it just goes into the nose. The oxygen, again, it's limited. You can only do up to 6 liters a minute in the nose. If that is not enough, then they can upgrade. I don't know if you want to call it upgrade or downgrade. Okay, the high flow oxygen, which can do is much more powerful, can do much more. Sometimes they have to use a BiPAP. BiPAP is similar to what people have at home. If you have sleep apnea, you would have a CPAP. It's very pressurized air, and sometimes they go through step by step until they have no choice and they have to intubate. But the question is, if a patient is, let's say, on a high flow, can I reduce it? The question is, and we're going to come up with that question, is going to come up soon, can you downgrade? Let's call it downgrade. Can we downgrade from a higher level oxygen to a lower level oxygen? The question is, what's the intention? If the intention is, the hospice doctor tells you that we know what his intention is, then that's a big problem. You have to speak to the Rav and find out. But if they want to wean him off and slowly but surely get him back to normal, to baseline, then why not? So whenever a doctor wants to change certain things, it's okay to ask questions, okay? They prefer patients or family members who ask questions as opposed to those, just do what you want, just do, I rely on you and that's it. We're going to soon see how important these three, oxygen, hydration, nutrition, how practical it is and how much information, this information is so valuable. Okay, how do we decide? And of course we know communication is the key for everything. When a patient gets diagnosed with any kind of a serious injury, serious disease, okay, they choose a doctor. This is going to be the oncologist. I heard about him, I'm going to use him. This is going to be the cardiologist. Severe heart disease, I chose this cardiologist, or whatever other doctor it may be. When you choose the doctor, choose the rabbi as well. And I'll say that again and again. Why? Because the rabbi has to be there to hold one hand and the doctor the other hand. Together, you're going to go through this whole unfortunate, this whole road. You get this whole path, this whole disease. You have to go through having the rabbi on one side and the doctor on the other side. Because, again, if you want to do things according to halacha, there are a lot of questions all along the way. I know individuals who call doctors in the middle of the night. I'm sorry, call the rabbi in the middle of the night. You know the joke with the rabbi and the doctor? The rabbi was once called in the middle of the night, and the rabbi was asked, should I take this medication? I don't know what to do, rabbi, help me. So the patient said, the rabbi said, you should really call your doctor. Why are you calling me if you should take this medication? He says, do you really think I can call the doctor in the middle of the night? So But anyway, rabbis are called in the middle of the night. And I know more than one case. Rabbi, what should I do? The doctors tell me, they just call me, they have to intubate. Should I do it? Should I not do it? I don't know what to do. The first time the rabbi heard from the family, I have no idea what's going on with your mother, father, whoever it is, okay? They'll probably have to sit on the phone for a half hour to get all the information. I can't just tell you yes, no on the spot. Just like a doctor, you can't just ask a question yes, no. I need to have the history. I need to know all about this patient before I can give you an answer. It's not fair to do that, and you're not going to get most rabbis won't give you an answer on the spot, and you're going to lose out. So the best thing is call the rabbi and tell him this is what happened. I want you to help us, and there'll be questions along the way. I'll keep you posted. And another important thing, just because a rabbi gave you a psak, gave you a ruling on Monday, doesn't mean that ruling will be also for Tuesday or Wednesday. If the patient's situation changes, if suddenly the patient gets more critical, you may have to pick up the phone again and tell the rabbi what's going on. Because whatever I said yesterday was good for yesterday, his condition of the patient was yesterday, but today I have a different answer for you. Yes.
You said call the rabbi. My answer to that is there's a rabbi and there's a rabbi.
Oh, so I want to talk about that. Right, that's another thing I wanted to say. When you choose a rabbi, it's okay to ask him, are you familiar? Do you have any experience with end-of-life questions and halachas? Okay, this is it's like anything else. Any other, there's an attorney who specializes in divorce, and some attorney has specialized in business law. Every attorney has something else. Just because he's a rabbi doesn't mean that he has smicha, that he knows everything, he's fluent in all the halachas. No. And I know recently there was a rabbi here in the community, very, very prominent Rav, and there was a very serious question, and he said to him clearly, the family didn't even ask him, are you okay to answer this question? He just said it to him, I am not familiar with these halachas. Call so-and-so, this and this rabbi would be much better for you to call. So it's okay for us to ask, is this something that you are comfortable to deal with? Is it nothing wrong to ask that question? I want to tell you something. When you ask a Rav, and you do what the Rav tells you, ultimately, down the road, as they say, 120, right? You'll never feel guilty. You'll never have any feelings of guilt. Did I do the right thing? I see this so often. Did I do the right thing? I should have done this. Maybe I could have tried the other thing. Should have, could have, would have. And this guilt can sit in the person for a long time. You'll need counseling to get rid of it. If you ask a Rav, it's a psak, it's a Torah ruling, a psak from a Rav is Dvar Hashem, Zu halacha, then there's no question. This is what I had to do. I have no guilt. I did exactly what the Torah wants me to do. I asked the rabbi, I carried out what the rabbi wants me to do, and the rest is up to God. And again, if you, ben Torah, as we call it, if you're somebody who carries out, and pretty much you want to carry out everything that the Torah says 24/7, then really this is the way to go. It's not really it's not a voluntary thing. It's really an obligation. We have to get to know what is halacha before we move on. So patient, doctor, rabbi, a three-way decision-making process. The patient or family member describes symptoms to the doctor. The doctor provides a medical diagnosis and treatment options. The rabbi consults with both patient and doctor and then guides the patient how to proceed based on the principles of Jewish law and the individual circumstances of the patient. It's critical that you don't make the final decision only by the conversation you had with the rabbi. Why do I say that? Because don't forget, you have to share with a rabbi what the condition of your loved one is. Okay? How do you know the condition? You heard it from the doctor. You may be missing out on one or two essential, critical words that changes the whole sack. So it's really important that you get the doctor and the rabbi, let the rabbi hear it firsthand, not secondhand. Let him hear it directly from the doctor what exactly is going on. Again, if it's really simple, is one thing. But you know what? What may really appear to be simple to me may not be simple to the rabbi. So the best scenario is call the Rav today. You can use a phone. You can have you can add another person on your conversation. Rav, are you available? Can I put the rabbi and the doctor on the phone? It's probably easier to get a hold of the rabbi than to get a hold of the doctor, but make an effort, and it gets done all the time. Another thing I want to say is sometimes, not usually, but sometimes family members have their own personal agenda. You know what? I've had it. It's such a long time. I've been caring for my great-grandmother for such a long time. It's disrupting everything in my house. I have no koyach. And because of that, it's possible that she or he may not give over the accurate facts to the Rav, and therefore the psak won't be 100% the proper psak. So again, trust me, it's the best thing to do. Get all three on the phone at the same time. Okay. Just waiting. We have plenty of time. Okay. So, dilemmas in medical ethics. So we have, this is a case of a patient who is in pain, has unfortunate cancer that metastasizes all over the body, for which medicine has no cure. Unfortunately, medicine has no cure. They tried chemo, they tried, maybe even the patient had surgery and everything you can think of, radiation. Nothing works anymore. Should the patient receive the following? So on your left, you'll see natural needs, ordinary interventions, and extraordinary interventions. Now, I'm not talking about the patient being in hospice. Many times, doctors will say, yes, at this point, hospice is your choice. But if you speak to our Rav, hospice may not be the choice. The patient may still live for quite a few months. Okay, he's not going to live for a year, maybe not, but he may live 5, 6, 7 months, But slowly, obviously, the patient is going to get weaker and weaker. So these questions will come up. The patient can no longer live without oxygen. Should we give him oxygen? Nutritional hydration, we spoke about before. Pain medication. Everybody agrees on pain medication. Okay? We don't want anyone to be in pain. The only thing we have to be careful is you see on the right column, Jewish medical ethics, yes, give medication with careful moderation. Because some medications can cause, can expedite a person's passing. Morphine, if you give too much morphine, it's known that can happen. So always the best rule of thumb is to ask the doctors if it's necessary to give morphine to start on a very small dose. Then you see slowly if we have to give more and more. By the way, pain medication, nurses, if the patient is in a nursing home or anywhere in a hospital, the nurses usually have a right to give pain medication as needed. They don't have to call the doctor 2 o'clock. I think the patient is in pain. Should I give him? If you think he's in pain, give him. It's one order. Whenever needed, you can give it. So you're really relying on the patient, on the nurse. Okay? Should I not give? It's not a bad idea to tell the nurses, to let you know, the family member, when will you increase the dose? Let me know. Okay, I want to know, I'm talking about these three things over here. I want to know when is the time to increase so I can be, I can be on the same page as you. So these three things, forgot I have this, I can use it. Natural needs, ordinary interventions, and extraordinary interventions. So the natural needs, as I said, oxygen, nutrition, hydration, pain medication. What about IV antibiotics? If the patient now has a secondary problem, of course, the patient has cancer, but then now developed a pneumonia. Should we treat the pneumonia or not? So you'll find that pretty much along the line, with the exception of the pain medication, modern medical ethics will say quality of life and age are significant factors. That may not be the only factor, obviously, but they take in consideration how old is the patient? Should we now give them hydration and nutrition? Should we give them all that? We'll give them a little bit of fluid, but do we have to give them nutrition? And all the other quality of life factors that we spoke about earlier. But halacha says always provide. Look on the right column. Unless it may cause harm. As we said before, sometimes giving fluid, even nutrition or hydration, may cause more harm than good. If that is what the doctor tells you, and this is in consultation with your rabbi, then the Rav may say, okay, we have to reduce or totally stop the feeding. Blood transfusions. I recall recently there was a patient who was critically ill, and he was losing blood, and they had to give him a blood transfusion. Okay? Guess what? A few days later, another one. A few days later, another one. And the doctor said the patient is so sick that they were unable to scope and find out exactly where he is bleeding from. It was impossible. They couldn't do it. That's how sick he was in ICU, of course, on a respirator. So what do we do? Again, this is a very, very important question to ask a Rav. Do you just keep on giving him transfusions every 3-4 days? I'm not going to give you the answer. So generally promote, exceptions may apply, especially when more harm than good is done. So these are all questions that the rabbi that you chose many months ago, okay, and you're still holding his hand, he should be the one to answer these questions. Thoracentesis, I don't know if anyone knows what this is. It happens very often, especially with cancer patients, that they have a buildup of fluid in the chest, it can be the legs, and what they do is called pleural effusion, and they have to, basically they stick a needle in and they drain out the fluids. And sometimes there are patients that every few days, you gotta do it again, How many times should I do it? That's a question for the Rav. The doctor will probably say, it's enough. You can keep on doing it. By the way, they can attach a catheter where you don't have to stick the patient every few days, but it drains into the catheter automatically. But still, nevertheless, it's constantly draining and draining. How long should we continue like this? Dialysis. The patient is that sick. Should we put the patient on dialysis if necessary? Should we intubate the patient? Should the patient get a trach? A trach is when you can only put the patient on a ventilator and put a tube down the mouth, down the throat, only for about 2 weeks. After that, the doctors would recommend a trach. So again, the question is, should you put a trach or not? The patient is so sick. Is that what's required or not? So again, modern medical ethics basically will give you the same answer. Let's sit and talk about it. Well, the rabbi will also say, let's sit and talk about it. But usually, the doctors will be either with giving up or will convince the family to let go much sooner than the rabbi will. And again, this has to be a discussion. Next page. Example number 2 is about discontinuing. The first page we said, again, the same thing. Patient is very ill. Can we stop? Can we stop dialysis? Can we stop intubation? Can we downgrade the oxygen method? So again, modern medical ethics, all these things, discontinue feeding tube, deactivate pacemaker or defibrillator. If the patient has one, they have a way to discontinue it, to deactivate it. Should they do it? The patient is dying anyway. So the answer is, again, if you ask a Rav, the first answer will be no. Let's try to continue. Exceptions may apply, and it has to be a Rav to tell you whether this particular patient is one of those exceptions. I want to talk about the last thing. What did I do? Right over here. So in these cases, it says the rabbi should consult with the patient's current PCP or specialist who originally prescribed the pacemaker, for example, the insulin. Why? Why can the doctor on the floor, why can the ICU doctor, they call it hospitalist, why can't they decide, you should discontinue the insulin or deactivate the pacemaker? And the answer is, from the information that I got, for example, a pacemaker, it gets programmed. It's not programmed the exact same way for each patient. The one who would know best why originally did this patient get insulin, okay, why originally did he get the defibrillator, is the one who originally decided to have it done. Go back to that doctor. He knows the patient. He knows exactly the history. Let him talk to the rabbi to decide whether it's time to discontinue. Because again, the doctors on the floor don't have the history, and they don't necessarily even want to go back and look up the history. Yes?
So, this has come up a lot in the last 10 minutes. Is there actual negotiation between the rabbi and the family and the doctor? The doctor says, he wants to, he's looking at the end of life. And the rabbi says, there's more life there. The family says, I want you to continue. Do they often negotiate?
Okay, so the question was, do the doctors often negotiate with the rabbis? I want to use the word negotiate. They will discuss. They will talk together. I think 90% of the time, that I remember, the doctors were okay with it. They didn't want to see somebody who was irrational. So, a family member, a grandchild is coming in, he's saying, do this, do this, do this. You don't know what you're talking about. Like, why? Right. If they hear it from a responsible person, from a respectful individual, learned man, a rabbi, and he's got experience, and he says to do it and do it up to this point, and then they accept it. There were a few times that I remember, and I was involved, where they said no, and we're going to call the ethics committee. All due respect, Rabbi, we're going to ask you to sit on the ethics committee in the hospital, explain them why you're doing X, Y, Z. We don't think that's ethical, so please. And when we explain it to them, usually they respect it. Okay, I will take questions soon. Okay, but this is really, really important. Get the original doctor or the family doctor, the PCP, primary care doctor, to be involved as well. As you know, that when a patient ends up in the hospital, usually your own primary care doctor is not involved. There are hospital doctors that are involved, but it doesn't mean that they can't call and talk to each other. Your primary care doctor probably won't come and see your loved one, okay? But if you tell the doctor in the hospital, please call my primary care doctor, I want you to talk to them about X, Y, Z, they'll do it. Okay. I'll take questions in. Okay.
Not a question.
Not a question?
Not really. I guess to the question is of do they have meetings? The rabbi and working in the field.
You should.
That I did. There was often many family meetings with the doctor,
and the family and the rabbi, myself in particular, Ari, where we discuss all these things. Because one other issue that comes up a lot with the family dynamics is that you have family members that are not in the same sheet of music.
Right. Okay. I can't talk about everything. You're
No,
right.
but-
Sometimes you have family members, and some family members want one thing, other families want the other thing. So you have to come to some kind of a. Maybe the rabbi is the one that can, negotiate with the family. Okay. In every situation, Jewish medical ethics require that an expert rabbi always be consulted, since the unique combination of individual factors in each case may lead to a different outcome in Jewish law. So we ask doctors not to compare one case to another, and we ask family members. Oh, my grandfather, the rabbi said this. So my grandfather, he said this. So probably my grandmother will say the same thing. No. Start all over again. Speak to the rabbi and the doctor. It may be, in your eyes, it's the same thing. It may not be the same thing. Okay, I'm going to go through a little. What is palliative care? Palliative care helps patients with serious illnesses manage their symptoms and improve their quality of life. Focuses on easing pain and discomfort. Usually, when palliative care is called in, it's because the patient is in a lot of pain, and they feel that palliative care can manage the pain, okay, and the discomfort, reducing stress and helping people have the highest quality of life possible. Palliative care, the last one, palliative care, I want to talk about this, may facilitate a smoother transition to hospice care if appropriate. I know some of listeners, and maybe some of you here in the audience may disagree, but I think that the majority of the time that palliative care is called in. Palliative care is not called in when a person has kidney stones. Oh, let's call palliative care, he's in such terrible pain. Let's call him in. Somebody fell and fractured the femur. Excruciating pain. Let's call palliative care. No, unless you don't want to do surgery, then maybe you should. Okay, usually palliative care is called in when it's a critically ill patient where most likely there will be this transition to hospice very soon. Let's start with palliative care. So, some may argue and say no. I spoke to someone last week. He said he knows many cases where palliative care was called in, and then they were discharged. The patient was discharged, no longer needs palliative care. Guess what? I know patients who were hospice patients, and they were discharged from hospice too. But those are the exceptional cases. Usually, it doesn't work that way. So, what is hospice? Provides comfort and support to people who are near the end of life, with a life expectancy of 6 months or less if the disease runs its normal course. Again, sometimes, to everyone's surprise, God intervenes like always, and all of a sudden, He lived through the 6 months. Then they have to, apply again, and sometimes they go a second round. If hospice focuses on managing pain and symptoms rather than attempting to cure disease or prolong life. So hospice is not there to prolong life. They are not there to cure the disease. Instead, they assist patients to get through the last stages of life, and the dying process comfortably. Hospice offers physical, emotional, social, and spiritual support for patients and families. Now, it's very important that you listen into this. Hospice may encourage to discontinue some or all of the patient's previously prescribed medications, treatments, and lab work. Because again, go with the philosophy, he or she is dying anyways, so why do we still have to give them the insulin? Why do they still have to have these medications, high blood pressure, whatever? Let's discontinue this and that. They may not say all in one day. Okay, this patient was admitted into hospice. Okay, take all the medications off, remove everything. They may do it slowly, but that is their goal. They also discourage emergency room visits. So if you want to take the patient to the emergency room, you have to discharge them from hospice, and then when they come back, you can admit them into hospice again. This is a major, major halachic problem. Because if hospice says discontinue certain medications or certain treatments, again, we spoke about it before. Discontinue means you have to ask the rabbi, is it okay for me to discontinue? Now let me say this. I'll tell you what's in 2 words. There's such a thing called active or passive. Actively causing someone demise to go quicker, okay, to expedite someone's demise, that is in Torah law forbidden. If it's done in a passive way, sometimes the rabbis will agree. Don't refill the medication. If it's really extremely, the patient is extremely ill, sometimes they will say that. Or what they also call I've seen that, withdraw, okay, to withdraw or to withheld or withdraw. Withdraw is like actively, I'm gonna withdraw, I'm gonna take him off the machine, take him off the oxygen, and withheld means I am withholding it. That means I'm passively allowing the patient just to go without medication. I'm not doing something. The outcome is the same. And therefore, by the medical ethics, as far as they're concerned, it's the same thing. The outcome is the same. But halachically, if you're doing something passively, it's not called ritzich. It's not called you're killing the person. It's done in a passive way. So Jewish medical ethics, almost done. For palliative or hospice patients, the general rule is always provide the best available treatment. Before making significant decisions, patients must consult with a rabbi experienced in the field. So I listed over here, anytime they want to discontinue any medication or treatment, begin a new medication. We're going to start them on morphine or something else, or make any changes in nutrition or hydration, call the rabbi. I've been talking to quite a few rabbis here in town the last few weeks, and they all told me that we think that our phones are going to be ringing much more often now. You know, how many people are you going to have over there? You know, okay. And finally, pardon?
But they're okay with it.
Yeah, okay with it. Finally, a summary of the Torah's view of the doctor's responsibility by Torah law. Okay, when treating sick patients, we have 3 different categories. A doctor is treating sick patients. A doctor is treating incurable diseases, and when all available treatments are futile or too risky. Don't like the word futile, I'll soon tell you what I meant by futile. So, when a doctor is treating a sick patient, okay, what's his goal? Cure the patient. That's your goal. Do everything possible, provide best treatments, okay, do everything you can, make sure the patient is pain-free, symptom-free, cure him, because it's a curable disease. Nobody argues on that. What they may argue is the last line. Patient should be full code, no DNR. DNR means do not resuscitate, which means if the patient stops breathing, his heart stops, then they will do CPR. Okay? But if the DNR means do not resuscitate, they will not do CPR. So that becomes a question of whether you're expediting a certain person's demise. And I know people who are 50, 60, they already wrote up a living will. They never want to be on a respirator, period. DNR at the age of 50, 60. Okay, not 90 to 95. So by Torah law, you can't do that. Unfortunately, some hospitals, DNR may be translated as DNT. You know what DNT is? Do not treat. So, do not treat. So if the nurse is taking care of 5 patients, and 4 of them have a curable disease or whatever, one of them is a DNR, okay, then, you know, if she's called by 2 patients, where is she going to run first? No one is going to admit to that. And I apologize if anybody's listening and I'm offending anyone. No one will admit to it, but it's human nature. It's human nature. If you see somebody who's so old and fragile, and DNR, you know, and the other one is a younger person, and he needs my help, I'm going to run to the younger person first. But if it's not DNR, they may look at it a little bit different. So the last thing you want to do is add a DNR. I happen to be a POA for quite a few patients. I'll tell you what I do. I don't allow the DNR, even terminally ill patients. But what I do is I make sure someone is there in the hospital when I see it's really critical. Someone is there in the hospital till the end. And then, if all of a sudden his heart, and it happened more than once. His heart stopped, I got on the phone, do not resuscitate. Because it was approved by Rabbanim, do not resuscitate. So up until that point, they gave him the best treatment. They gave him everything he possibly can have, okay? But when his heart stopped, they said, okay, Atkan, don't do it. At that point, nothing to worry about anymore. But again, you can't always do that, so every case is different. The next thing is to cure a patient, the next thing is if a doctor no longer has a cure for the patient, what's his goal? By Jewish law, the goal is prolonged life. If it can be done without major setbacks and without doing any harm, obviously. We don't want to do any harm, but if the patient is still, eating and he's still around and whatever, even if he's not eating, but he's getting nutrition, he's communicating, don't do whatever you can, treat him in every possible way to provide the best possible treatments, manage patient symptoms, and make sure, of course, he's pain-free. At this point, DNR may be appropriate. This is where the rabbi comes in. Sometimes, if it's really, talking about almost a goises. The term goises means the patient is like dying imminently. He's in the process of dying. But this is much before that, so sometimes Rabbanim will allow. And finally, if you tried everything you can to prolong life, you did everything you possibly can, and everything is failing, then the only thing that's left is comfort care. But as you see, hospice care with rabbinical guidance, as we said before, what they can add, what they can take off. Don't make those decisions that quickly. Many times we have palliative care doctors come in and they talk to the families and they help you decide what to do, what not to do. Just tell them, very respectful, just tell them that you're from the Jewish faith and you need to get the rabbi involved, and I'll be very happy for you to talk to the rabbi. What else? Here's another important thing. Oxygen at this point, yes, always give oxygen. Hydration and nutrition, again, if no harm is done, you should continue giving IV fluids, continue giving nutrition. And again, how many times did I say it? Doctor and rabbi should talk. That's how important it is. Finally, everyone should have an advanced directive. Either delegate someone or a family member, and if you use a halachic advanced directive, they have actually a line there. Who is the rabbi who you would like to contact if halachic questions arise? And use the halachic advanced directives. It's available online. You go to the Agudah website. It's available for every state. It's different between each state. And if the hospital offers you one, say, no, thank you, I want to get a different one. And they accept it, it's recognized.
Rabbi Wolf,
Yes.
just one point, in doing estate planning,
Yes.
when you go to your lawyer, I know when I went, my wife and I, it was my cousin, but anyway, he asked about the medical power of attorney.
Yeah.
And what I said, and in the power of attorney that we put out, I said it has to be, with consultation of a rabbi. So good lawyers and estate planning will do that.
Okay, but there has to be a lawyer who
knows
aware of
about
this.
it.
Yeah. I know it's late. I'm here. If you have any questions, otherwise help yourself. Go ahead.
On that same note, should we now notify the rabbi that we put him in that, his name into that?
Absolutely. Yeah, because you may think that that's the best choice, and he may say, I don't want to be involved for whatever reason. Yes, the question was, should you notify the rabbi if you put his name in the POA, or the answer is yes. Yes, doctor.
So, many years ago, my uncle had a dementia and he sort of quit eating, and what I was told is the halacha was that you have to offer someone food, but you don't have to do more than offer. I mean, you're not obligated to do more than offer. What you're saying that's not the halacha. What do you think of that?
So the question is about.
Or have you heard that?
Okay, the question was, just for those that are listening online, I'll repeat the question. The question is it enough that you just offer the food to the patient? Okay, so the answer is yes and no. Is the patient able just to pick up the food, put it on the tray? Is he able just to pick it up and eat it, or does he need to be fed?
He needs to be fed, but if he won't take the spoon, he won't, because he's got a bad dementia. So you feed the guy and he, doesn't take it.
Some dementia patients can no longer swallow. It comes to a certain point where they cannot swallow. So you have to find out, is there a swallowing problem? If that happens, okay, he doesn't want to eat or he's spitting it out, you have to find out. You don't want to force food into him if he really can no longer swallow. So once you find out, they have ways to figure that out.
Right.
Speech therapists do it usually. So once you find out that he could swallow, then you figure out, you grind it, you make it a puree, you put some chocolate coating on top of it. I mean, if he could eat. But if he doesn't want to eat, there's only so much you can do.
But so you're not necessarily obligated to put in a feeding tube, or a G tube, or a J tube?
Oh.
That's my question. Do you need to be invasive?
If he doesn't want to eat because of his dementia, he doesn't want to eat, maybe he doesn't understand anymore that food that goes in his mouth he has to swallow. Okay? Then it's a discussion with the rabbi, depending on the stage, exactly where he is, whether a feeding tube should be inserted.
So it's not just blanket, do everything to
No, the
give
answer is,
nutrition?
yeah, most likely the answer would be yes.
Okay.
A feeding tube is usually not an invasive procedure. Maybe for some patients it is, but usually it's done. I know a doctor here that does it all the time, and it's.
Yes.
Am I right, doctor? It's not.
No,
It's
it's
not a
an
big deal.
invasive procedure to put the tube in, but once it's in and established, then that it's not gonna interfere with the quality of life.
You'll have doctors that will do whatever they can to persuade the family, do not get involved with the feeding tube. And they'll give you reasons. It can cause infections. The patient may still aspirate. If that was the reason you started with a feeding tube, that's why you want a feeding tube, he may still have aspiration pneumonia. He'll pull it out. You can end up going to the emergency room every so often to put it back in. They'll give you all kinds of reasons. But halachically, if you don't do it, for sure, we know what the end is going to be. If you do it, there may be a chance of infections. These things may happen. So,
Okay, thank you.
yes, Rabbi.
Just so I think what I have seen from experience when
This is Rabbi Marinelli. He is the rabbi of Evanston for all North Shore hospitals, Endeavor hospitals, and it's thanks to Rabbi Marinelli that we have amazing services in the local Endeavor hospitals. Thank you.
Thank you. So when I've heard Rabbanim react to the quality of life question, typically, yes, they do say, we wouldn't necessarily buy into this idea of quality of life because it's very subjective. However, I have seen that Rabbanim in general, or the halacha, is definitely sensitive to the question of suffering. And when it's pain and suffering, so then you get a lot more, okay, so that might change factors.
So,
Yeah.
Okay, so the question, it's a statement that was made that many times Rabbanim do take in consideration the suffering of the patient. Okay? But I also want to bring out one point which I forgot to say. exact same question, what else is new? That you may ask Rabbi A in Chicago, who'll give you one answer. You may find another rabbi somewhere else to give you another answer. Did that ever happen?
Yeah.
It happens with everything, right?
Sure.
Okay, because he's relying on this opinion and that opinion, whatever. So that's why it's important. By the way, when I went to prepare for today's presentation, I spoke only to local rabbanim. So this is pretty much where the local rabbanim are all on the same page. But you may, and I think it's important to stick to one road. Don't go rabbi shopping because you get all confused and you won't know what to do. Because he said this and he said that, and you'll confuse the doctors and it's going to be a mess. But yes, doctors, rabbanim, do take in consideration the suffering. But when a doctor says the patient is suffering, we really have to analyze what does that mean. Sometimes there's more suffering from the family than the patient. The patient is, comatose, or the patient is sedated, and the family is sitting there crying, and they're ois mensch, as they say. They're suffering, and sometimes much more than the patient. But again, every case is different. This has to be part of the discussion. Yes.
The other point about hospice patients, there have been, I think, numerous studies that have shown that when patients are in a certain level of critical illness, being on hospice, they've lived longer.
I was waiting for that question because I saw that. I think it was the Dr. Alexander that made that. There was a study made. But you know something? I have yet to see, and I went through in the last few weeks, I went through so many websites from hospice agencies. I have yet to see one hospice agency advertise, we prolong life.
No, that's not necessary.
But if the patients are admitted to us, they're going to live longer than otherwise. Anything along those lines. There was a study that was made. I saw that. There was a study. My doctor, name was Dr. Alexander. He did a study that he compared patients, exact same disease. Again, it's very hard to say exact same disease, but as much as he was able to compare, patients who went into hospice, patients who did not go to hospice, and those who went to hospice lived longer. That's the exceptional case.
Where did the other ones go? They didn't go to hospice where they
They didn't. They just kept on doing all kinds of treatment.
They get more support in hospice sometimes.
Sometimes the invasive procedures could actually lead to a person's demise happening quicker.
Let the rabbi decide yes hospice or no hospice. Will that help the patient or not? Yes.
So just one more. So I sit on the ethics committee.
Oh.
A lot of this is something I think that's misunderstood by families and by the medical team very often, is that the ethics committee is not really supposed to be the ethics police. It's supposed to be a consultative body. They're not a decision-making body. They're supposed to kind of sit together in a supportive role and within the context of ethics and work together with the family and with the medical team and with the rabbi to build up some kind of consensus that would be in the best interest of the patient. Now, what you're going to have in every ethics consult, or every ethics committee meeting is you're going to have varying views, and the views are definitely going to be distinct depending on whether the person's coming from a Torah background or whether the person's coming from a medical background. But nevertheless, the goal is to take all these different views and kind of in some way develop some kind of consensus that they find to be that would be in the best interest of the patient. Now, what you're going to have in every ethics consult, or every ethics committee meeting is you're going to have varying views, and the views are definitely going to be distinct depending on whether the person's coming from a Torah background or whether the person's coming from a medical background. But nevertheless, the goal is to take all these different views and kind of in some way develop some kind of consensus that they find to be in the best interest of the patient.
I would hope one day that, talking about Evanston Hospital, where I would say the majority, between Evanston, Lutheran General, St. Francis, these are the hospitals where the majority of patients from this neighborhood end up going, that the ethics committees in those hospitals meet together and we have an opportunity for them to learn more about Torah medical ethics. Once they know that, when we sit together with them, they'll look at it very different, and they'll respect it from a different angle. Most of the time when they come there, it's all new to them, all new. We have to educate them, like, why are we here? I was in the ethics committee, not because I was on the committee, because I was asked to come for a patient, and they were arguing 15 minutes back and forth. Why do we need a rabbi? Why do we need a rabbi here? Okay, so that comes from a lack of understanding. Okay, I wish you all the best. No one should ever have to put all of this into practice, and this should just be the knowledge itself, and everybody should live long, happy, and healthy years.
Yeah.